Hi, good morning Indonesia and good afternoon Brisbane. Assalamualaikum warahmatullahi wabarakatuh. My name is Yanuar Primanda. I am a PhD student in Nursing, Faculty of Medicine, Faculty of Health, Queensland University of Technology. I will be your moderator in the fourth session of mini conference of Indonesian students in Queensland, organized by Indonesian Students Association of Queensland University of Technology or ISAC in collaboration with Kelas Bersama Perpustakaan Kemdiknas Indonesia. Today we will have a three session, so please stay tuned and don't go anywhere. For you who do not register yet, please register through the link provided in the live chat room, and active participants will be selected to receive merchandise from our sponsors. This event is sponsored by Interested Education in Jakarta, Sendok Garpu Brisbane and Jakarta, Universitas Indonesia, and Anak Brisbane. Thank you for all sponsors for their valuable contribution for this event. Before we start the session, I would like to introduce our distinguished speakers in this session. The first speaker is Mrs. Ferika Indarwati. Mrs. Ferika is a lecturer in Pediatric Department of School of Nursing, Universitas Muhammadiyah, Yogyakarta. And now she is doing her PhD in School of Nursing, Faculty of Health, Queensland University of Technology. She finished her bachelor degree in Diponegoro University, Semarang, Indonesia, and she got her master degree from Flinders University, South Australia. She received Australia Award Scholarship for her master degree, and now she is an LPDP awardee. She has published her works in various reputable journals in national and international journals. Now, she is conducting research on scoping study of peripheral intravenous catheter in pediatric patients. Her most recent publication was published in International Journal of Nursing Studies with the topic that related to her presentation today. Today, the title of her presentation is Incidence of Peripheral Intravenous Catheter Failure and Complications in Pediatric Patients, a Systematic Review and Meta-Analysis. The second speaker is Mr. Edwin Adrianta Surijah. He is the second year student of School of Psychology and Counseling, Faculty of Health, Queensland University of Technology. His expertise is related to psychology of love. Love. So, whenever you need consultation about love, you can contact him for further consultation. His presentation today related to his study about marital satisfaction. It is commonly found that marriage life is sometimes fluctuated. Couples may in the peak of their happiness during their honeymoon, but maybe several months after that, things can change. They start to fight each other. So today we will learn more about that. And the title of his presentation today is The Trajectory of Marital Satisfaction. So let's begin with our first speaker presentation. Mrs. Ferika Indarwati, time is yours.
Okay, thank you, Ibu Prima and Isa Cutie for the opportunity. So I would like to share my PowerPoint screen first. So, yep, I hope all of you now can see my presentation slides. So I would like to say hello or good afternoon for all of the audience in Brisbane, and also good afternoon for those who are in Indonesia. And Assalamualaikum warahmatullahi wabarakatuh. So today I would like to share one of my research entitled Incidence of Peripheral Intravenous Catheter Failure and Complication in Pediatric Patients, a Systematic Review and Meta-Analysis. So this presentation will be organized as follows. So first, I will explain the study background, followed by the aims, method, results, discussions, limitation, and also its implication and recommendations. Okay, so now here is a little bit of the background of what PIVC is for those who are not familiar with this medical term. So I think uh, most of you, when you're hospitalized in hospital, you will get one PIVC insertion during your stay, right? So PIVC itself is first found in the 16th century. It was made from a goose quill and originally developed to administer opium into dog's vein to help the dog recover from his illness. But nowadays, we are not using the goose quill anymore, but instead, the modern PIVC is made from Teflon or polyurethane materials, and it is inserted into human vein through the help of the metal needle stillet. PIVC is commonly used to deliver intravenous drug, fluids, nutrition products, and also blood transfusion products. And approximately more than 2 billion PIVC is used worldwide annually and 1 million in Indonesia. So it is quite a big number, right? So not surprisingly, PIVC insertion is the most frequent invasive procedure done by nurses or doctors in hospitals. Okay, now let's continue with the PIVC in pediatric patients. Is it similar or different from the one in the adult patients? So actually, in terms of its function, it is very similar, which is to deliver IV treatments for the patients. However, the insertion and maintenance of PIVC in pediatric patients is more challenging than in adults because of smaller veins and less patient cooperations. So these challenges lead to a relatively high PIVC failure and complication in this population. Several individual studies have reported that the first insertion success in pediatric cohort ranged from 45 to 68%, and between 34 and 56% of the PIVCs have to be removed before the completion of the patient's treatment because of complications. Nevertheless, the evidence from these individual studies has not been synthesized, meaning that systematic analysis of the pooled incidence of PIVC failure and complications in pediatric patients has not been examined. And subsequently, we simply don't know the magnitude of the problem. So, based on the background, this study aims to provide overall estimates of peripheral intravenous catheter failure and related complications in pediatric populations. And its specific objectives are to assess the composite failure by country classification, developed versus developing countries, and also to assess the composite failure of PIVC complication by age group, neonatal, and pediatric, and to assess the incidence for each type of PIVC complication in these populations. Okay, here is the process of my study. So first, a protocol was made and registered to Prospero. Prospero is an international database of prospectively registered systematic review in health and social care. And in this protocol, we specify the outcome of interest of this study, which was PIVC failure due to any complication at catheter removal. And this included a composite measures of PIVC failure and individual complications such as phlebitis, occlusion, infiltration, extravasation, accidental removal or dislodgement, leakage, and infections. Okay, and we also specify our search strategy here. So a specific search statement were made from the research keywords, and search was conducted in 7 databases, namely the Cochrane Central Register of Control Trial, U.S. National Library of Medicine and National Institutes of Health, PubMed and Medline, Cumulative Index of Nursing and Health or CNAL, Embase, Joanna Briggs Institute of Database, and also ProQuest dissertation and thesis. Reference lists of the included study were also searched. This review included studies written in English or Indonesian from January 2000 to January 2019. The goal is to capture the current practices based on the International Nursing Association in Infusion Society in 2016. And this review included all experimental and epidemiological study designs, and as well as the RCT and non-RCT design. Participants included neonatal or pediatric patients aged from 0 to 18 years old with a PIVC in any hospital settings. Studies were eligible if participants were followed from the insertion of the PIVC until its removal. For the study selection process, so here, two authors independently screened titles and abstracts against the inclusion and exclusion criteria. Studies fulfilling the inclusions and the inclusion criteria were then assessed for their methodological quality, utilizing the Cochrane risk of bias for RCT studies and the Cochrane risk of bias in non-randomized studies for intervention studies. And the last tools is the Newcastle Ottawa scale or NOS for the cohort studies and observational studies. So the independent quality, the quality assessment were independently assessed and undertaken by peer reviewers, and a third reviewer was utilized for arbitration if we don't agree in some result of the assessment, right? After the quality assessment, so we will move to the data extraction. For the data extraction, the process is as follows. Four authors independently extracted data from the included studies using a data extraction form designed for this review and piloted for functionality. Extracted data included the following: authors, study designs, title, year of publication, country, setting, characteristic of participants, units of measurements, and outcomes. The incidence of composite PIVC failure and its individual PIVC complications were documented in this data extraction form. So in experimental studies, however, data was only extracted from the control group and not from the intervention group, because this was to obtain data that reflected the usual care at that time, because we're not gonna measure failure on complication in the intervention group, because the intervention, they got intervention which may alter the result or the outcomes. Okay. And for the data analysis, we use the Stata version 15 and its metaprop command. So we use the Freeman-Tucky double arcing transformation method. So the Freeman-Tucky is one of the mathematical equation in the metaprop command. So this mathematical equation is used to transform proportion and stabilize variance. And the Simonian layered random effect models was used to pull the PIVC incidence. The estimate of heterogeneity or I-square statistic was also calculated from the inverse variance of the model. Results were displayed in forest plots. So here we are. We got the systematic review and meta-analysis report at the end. Okay. So that's the method, and now we will describe our results from this systematic review and meta-analysis. So this is the Prisma flow diagram. Basically, this Prisma flow diagram shows us how we conduct this systematic review. So it shows us how we initially search our databases. So we identified for 587 articles from our initial search, and after screening, we ended up with 32 articles that were eligible to be included in our analysis. So for the study characteristics, so this 32 articles comprise like 11,100 patients and around 13,202 PIVC records were reported in these 32 studies that were included in our systematic review. 19 of these studies were a cohort study, 6 were RCTs, the randomized controlled trial studies, and 7 were non-randomized experiments. 65% was conducted in high-income countries, yeah, and most of it also being conducted in general pediatric patient characteristics. 66% reported the composite PIVC failure as the outcome, and 59% reported the individual complication, and mostly reported infiltration complication. The risk of bias. Okay, so I have told you that we also assess the methodological quality of the studies that we included in our systematic review. So we assessed the quality of the studies included, and we found that all of the RCT studies were rated as high risk of bias. It's mainly due to poor reporting of the randomization and allocation concealment procedures. Quasi-experiment and non-randomized studies included in this review had moderate to serious overall risk of bias because of poor control of confounders, unclear methods to classify participants or allocations, uncertainty of assessors' blinding. And the cohort studies were assessed for its selection, comparability, and outcome domains. It showed that it had good to moderate or fair quality. This because of unclear descriptions of the exposed and non-exposed cohorts, poor reporting of the ascertainment of exposures, and unclear methods to control for confounder. After the methodological assessment, we did meta-analysis to pull the incident using the data meta recommended. I've already told you before. Okay, now here the forest plot. Okay, the meta-analysis results of this study is presented as a forest plot. So from this forest plot, we can conclude or we can say that 1 in 3 PIVC failed before completion of therapy. Next, we also in a subgroup analysis, the pooled incidence of composite PIVC failures is also comparable between developed and developing countries. So there is no significant difference from these two country group. And based on the age group, it is noticeable that the incidence of PIVC failure is higher in the neonatal group compared to the pediatric group. So the smaller the baby or the smaller the children, they have higher risk of having PIVC failure or complications. Okay. And here, the last table or result of my study. So this table basically tells you about the incidence of each or individual PIVC complication in pediatric patients. So this table shows us that infiltration is the most frequent PIVC complication found in the patients, followed by the accidental removal, occlusion, leakage, phlebitis, and extravasation. Okay, from our study, we find that 1 in 3 PIVC inserted in pediatric patients failing before the completion of the therapy, which is comparable to rates in the adult populations. So it's kind of similar. 1 in 3 PIVC that been inserted in the pediatric patients failed compared to the adult populations. So it's kind of sad, really, because like in adult, you might you might notice that, or you might understand that inserting the PIVC is more easier compared to if we have to insert it in pediatric patients, because of the smaller veins and also like lack of patient cooperation. So it's really hard. And also for the pediatric patients, they are like more vulnerable than adults. And also we found that most of the studies included in our review use device or PIVC as the unit of analysis rather than the patients. This was considered not the best approach of calculating incidence for those who are in medical or health or public health. Probably you familiar with this term, incidence, calculating the incidence or prevalence. Patients should be used as the unit of analysis instead of the device to avoid repeated measures. Because sometimes we found that one patient not only have one PIVC inserted, they have two. So if you use the device as your unit of analysis, then usually you will find or you will get higher incidence rather than if you're using patients. If you use patient, you just count patient as one. But if the patient have two devices, then you count it. If you use the device, then you count the device as two if you have two in their vein systems. Okay. Beside that, we also realize that it is really hard to separate each individual complication from another. Often, multiple paths to failure are intertwined. For example, occluded catheter associated with leaking and infiltration, or poor scurements or poor bandage leads to gradual local irritation of the vein and may also cause dislodgement. So it's like intertwined each other. So failed PIVC also need to be removed, right? Because they no longer uh, have a good functionality. So as a nurse or doctor, you have to remove that from your patient, because if you not remove it, then it will create further complications. And you also have to replace it in the case that if your patient haven't finished their treatment yet, the IV treatment yet, so you have to replace it, put the new one. So what happened with that? It will become burden for family and patient as well as for the healthcare systems. Patients may need to stay in hospital for a longer period because of PIVC complications. Sometimes, for example, like if they experience phlebitis, they usually got like a blanching or like edema in their skin or in their hand, for example, and it's painful. So you have to treat it before you can go home. So they have to stay longer. And also, this is particularly evident for the catheter-related bloodstream infection. Okay, one of the child that you might seen in my slides previously, she has to lose her arms because of the infections going on, right? Because first she got the PIVC inserted, but then because of poor maintenance, the PIVC or the a bacterial infection happening, and then it makes the tissue around the insertion site necrotic, and it sadly she has to be the arm needs to be amputated. And in terms of the hospital costs, in average, the replacement cost for one PIVC procedure and care is calculated to be like around 85 United dollars, US dollar, or it's around 69.30 Australian dollar. If you times this with the annual use of PIVC, which is like around 2 billions annually, it will be huge. So, but here we understand that much of this failure actually is potentially avoidable with quality, evidence-based, and consistent insertion and maintenance practice. So, we also understand that our study is not without any limitation. So this study, we pulled the PIVC failure and complications and reported as incidence proportion. However, as we know that the PIVC complication and failure is really related to the time-based, it's kind of like time-based event. So time-based analysis, for example, like PIVC failure and complication incident per catheter days or hour is more valid, is considered as a more valid analysis reflective of PIVC incidence variable, which is a time event outcome. So you know that sometimes if we have like PIVC in our vein for a longer time, they usually have like higher incidence of complication because it's already stays longer in our vein. But if it's just inserted, you may have like a lower risk of uh, complication because it's just inserted. So it needs like a time uh, to to get the event or get the outcome, like get the complication. So furthermore, an avoidable high heterogeneity of the included population in this review, as well as settings and definition of the complication in its study, may affect the generalizability of the results. However, subgroup analysis address some of these limitations. For example, like if I have like heterogeneity in my populations, so I did the subgroup analysis. So I divided into neonatal and pediatric group. So this may overcome some of the limitation in this study. And these limitations are also reflective of the pragmatic nature of clinical trial, which enhance the generalizability. Okay, right. Now, so what? So what is the implication of these study findings for the future of the PIVC in pediatric patients? Just wondering. So, okay, this study actually brings us an understanding that quality trial evidence is urgently required to guide PIVC maintenance and care, mainly in the evidence of specific practice or product use to reduce the PIVC failure and complications. For example, like we need to know what type of PIVC dressing that is optimal to prevent like dislodgement or to prevent leakage, or also to prevent like accidental removal, because we have pediatric clients here that's really not really having understanding what's the PIVC or what its important function for their treatment. So we really need to have evidence or research or trial conducted in this area for the dressing. Okay. This study also supported that clinician training is crucial to optimize insertion and outcomes of PIVC in pediatric patients. Another salient point to emerge from our finding was lack of consensus in outcome definitions. For example, PIVC complications such as uh, diabetes, we found that each study has different definition and criteria measurements of diabetes. This also similar in what we found in infection. So some of them like use the laboratory confirmations criteria to judge or to clarify that infection is going on in this PIVC. So, but other study, they are not having any criteria related to the laboratory result. For example, is there any bacteria in this PIVC? So they don't really count that. They just see that the infection is just an infection. It just showed with the probably with the simplest symptoms like hot or warm in your skin and edema in your skin, like that. And from the epidemiological perspective, consensus on surveillance and definitions of its complication is required to accurately monitor and report outcomes in research and practice. So we will get like a valid measurement, and we can compare with confidently between studies because they all have the same measurements, they have all same criteria. So that's why. So it brings us more confidence for as a epidemiologist and also as a clinicians to calculate the incidence of PIVC complications. So I think that's all for my presentation today. And for those who wish to read the full article, you can hit the link provided below. So it's in the International Journal of Nursing Studies. And yeah, just go and see there. It's complete article there. And also you can get the supplementary materials, which I like recommended for you who like studying in health or in medicine. In there you can find the very rigid details of the results of the systematic review meta-analysis. Okay, thank you very much for your attention. I hope you enjoy my presentation, and probably I hope that I will not make you confused. Thank you very much for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Very nice presentation, Mrs. Ferika Indarwati, because this is very related to like a nursing practice. As we know that pediatric patient is very vulnerable for the PIVC insertion failure and complications. So I invite all of the audience to provide, to give like a question for Mrs. Ferika Indarwati. And we already have Mr. Gunawan Tanuwijaya. He asked that, is there any problem to do data gathering for your research during the COVID-19 pandemic? And how do you respond to the current hospital management situation? Thank you. Okay, Bu Ferika, it's clear enough, I think.
Yes, yes. Okay. Thank you, Pak Gunawan, for the question. So yes, actually for this systematic, I did not gather any data from the hospital, but for my big research, I mean for my scoping study, for my thesis, I do need to go to hospital to collect my data. And sadly, I have to say that it's very hard at this time of the pandemic when you have your data in the hospital, because the hospital now required all of the visitors has to be like they have to prove that they
Vaccine?
are not having COVID. Yeah. Yeah, they have to get the PCR or swab test or call it the rapid test. Yes, the rapid test. You have to show it before you can enter the hospital. And another problem is that now the number of patients in hospital is really low because of COVID-19, and all of the pediatric or the children are now stayed at home because they don't have any class. So, but this one is actually a good preceding, because I found that if the student stays at home, they're not really easily like getting sick. So the lower incidence or the lower number of pediatric patient in hospital is actually good, but not good for my research. Yeah, and how to yeah, not good for my research, but good in terms of the well-being of the children, right? So how to
Yeah.
overcome that thingy? So I just like divided my data collection procedure in 3 terms. So first, I did the online survey first. So I do not need to go to the hospital. But the second round of my data collection, I have to. So I couldn't like avoid it forever. So next year, probably, hopefully, if God allow me to do that, so I will come back to Indonesia and collect my second and third data round for my study. Thank you.
Okay, we hope that the pandemic will finish soon,
Yeah,
so everything is returned to normal.
yeah,
So
yes.
now we have a question also from Mrs. Cecilia Effie. This is like the sound of mother.
Oh,
As a mother, she asked that as a mother, I do have a traumatic experience with the IVC failure, where the
oh,
nurses did
yeah,
trial for 4 times before a
yeah.
senior nurse do the fifth trial.
Mm,
How can your research be translated into nursing? Yeah, we know it
yeah,
that for parents it's very traumatic also. So
yes, yes.
maybe you can answer.
Yeah, I'm very sorry to hear that, but Cecile, that you experienced a bad what's that experience related with the PIVC insertion. I know that it's really hard, like to insert the PIVC in children, especially the little one. I mean, like an infant or toddler is more difficult to get PIVC inserted. So sometimes we have to try like more than two attempts. So we have to try twice, like more than twice probably. But now we actually have a regulation for that. So if you fail in the second attempt, so what you need to do? So one nurse should not exceed like 2 attempts in inserting the PIVC in children. So if you fail in your second attempt, then you have to refer it into more experienced inserters. But then if the second inserters or the experienced inserters have failed, you have to consider of not inserting the PIVC, but instead you can choose another type of IV access. For example, for the midline catheter or the central catheter, if it is really needed to get the IV drugs. What's
Mhm.
that? IV drugs
IV fluid.
administered. Yes, administered. So that's the regulations. But by using this systematic review, we can like understand that the failure and complication is relatively high now, because 1 in 3 is not acceptable. So we aim to like reduce it, for example, like 1 to 5 or 1 to 6, right? Failure probably more accepted than 1 in 3. Okay, so by knowing this complication, the high rate, so we uh, pushing pushing the policymakers or the hospital in this case to like pay attention for the training of the nurses, so they can be like a professional or experienced inserters. So this one is to avoid the failure of the insertion, the first insertion. So that's how my research may help that may help the policymakers to understand that this what is that this problem is a big problem, and it's also like causing a traumatic effect for the patient, especially for the children and also the family. And probably I will like tell you that this traumatic experience can last up until adulthood. So I've come across a research or a study that's saying that if you got really a bad experience in PIVC insertion during your childhood, then in adulthood you will what's that procrastinate, or you will like avoid to go to the hospital, avoid to get help from the medical staff because of this uh because of your bad
experience.
experience, yeah, during your childhood. So it's really like not a good,
Traumatic, right?
yeah, yeah, it's not a good experience for them, and in the
Mhm.
the effect can last until adulthood. Okay, I
Wow.
think that's
So it's like a traumatic event for children when they got a
yeah,
failure in PIVC insertion, and
yeah,
also for the
for
parents
parents,
also. Yeah.
yeah,
Okay. Thank you, Mrs. Ferika. And the next question is also come from Mr. Gunawan Tanuwijaya. Is there any evidence-based research system that can be adapted from
yeah,
Australian hospital that can be applied in government hospital in Indonesia? Any
yes,
story,
yes.
maybe from your study?
Yes, yes, thank you, Pak Kunan. It's very interesting to see that the research conducted here is very like advanced, I can say. So got so many evidence or many techniques that we can adopt to Indonesian settings. But the problem with that is that we also need to conduct our own research because uh, we have a slightly different situation here in Indonesia, that the humidity and also the weather in Indonesia, we got like a high humidity, which is also have an effect into the incidence of complication. For example, the dislodgement or accidental removal, because of sometimes your dressings, the tape is cannot cannot be put
Yeah.
tightly in your skin
Mm.
because your skin is wet,
Uh-huh.
something like that. So in here in Australia, we don't have that kind of problem. But in Indonesia, if you see the patient in the hospital, sometimes the tape that we put in their IV insertion come off. So that's also will affect the incidence of accidental removal of or dislodgement of the PIVC inserted. So that, but I agree that we can like adapt something from the studies in Australia. And I also knew that Australia, particularly in the Griffith University, they have a really big research cohort for the PIVC. They have the vascular access research team,
Research
which
center.
produce, yes, research center, which produce really like highly valid evidence that can be used in the hospital to help to minimize the incidence and also the complication of PIVC in pediatric patients. Yeah.
And maybe I can add some that you said that the materials of the PIVC also will influence the
Yes,
incident also, and
yes,
maybe it's in Indonesian context with the high quality of PIVC, it means the higher price. So
yeah,
what do you think about that in
yes,
this JKN
yes,
era?
yes, yes. That's very true, Bu Prima. So uh, we cannot, sometimes we cannot avoid that if we got like a good material, it usually comes with a higher price or higher cost. So in Indonesia, for example, for the dressing, for the transparent dressing, which is better for PIVC, the price is higher or more expensive compared to the brown tape that we usually use. Okay, so that's because we really have a like low resource for that. So at this time, like BPJS is only covering that kind of tape, not the transparent or the beautiful one, the good one. So sadly to say that technology is sometimes only available for the one who have money or the one who are in a good financial condition, or the patient that has like their own private health insurance, not using the BPJS one. So if BPJS, you cannot choose, basically you just can have whatever the BPJS already agreed on, the plafond or the hospital cost. So that's
Uh,
a
yeah,
bit
it's quite,
hard.
yeah.
Yeah,
Okay,
bit
so
hard.
we have another question for Mr. Herdian Maulana.
Okay.
Have a question for you. Is that right that the intravenous catheter can be applied in multiple body parts? Is there any difference effectiveness between adult and children?
Yes.
Yeah.
Yes, the intravenous catheter actually we have three major types. So we have the peripheral one, midline catheter, and central catheter. So the peripheral intravenous catheter usually being placed in the peripheral venous system. For example, you can see here, if you can see the vein here, so it's the peripheral one. It's been in the peripheral or uh, in the edge of your body parts. But the midline is usually in here, or in your arm. You see it? No, you cannot see. It's here, and the central catheter usually in the big vein here. That's directly connected to your central venous system in your heart. So that's the difference. And also, you asked about, is it any different effectiveness if we place PIVC in this peripheral or midline or the central? Actually, the decision to replace the intravenous catheter, the peripheral one or the midline or the central one, is actually based on the prescription or the IV drugs that you receive. If you only receive like the common IV drugs, usually you only will get the peripheral one. But if you need those drugs in the longer term, you may get the midline or the central one. Okay. If we also found that if the peripheral intravenous catheter being placed in what we call in the joint, it usually have a higher risk of complication, or we can say that it's not effective if you put it in joint, because the polyuterine material, like if you put in the joint area here, it can like what we call it bend like this, and it will stop the IV drugs flows into our venous system. If it's bent like this and then it's stuck like this, if you got it here, then it will make like in or phlebitis here. Usually you can like the intravenous drug will stop here, stuck here, and it will create a painful sensation for the
Yeah.
patient. So
Mm-hmm.
please avoid, if a nurse want to put the PIVC in your vein, if they want to put it in the joint vein here like
Area.
this, you can say no, I don't want to get it here. I want it to get it here or here. So avoid this joint area. You can ask, because now you know that you not supposed to put the PIVC in the joint area. Okay.
Okay.
Yeah.
Thank
Yeah.
you very much, Mrs. Ferika.
Okay.
It was very
Yeah.
nice presentation. Actually,
Yes.
we have so many questions that we want to ask because
Yeah.
I think this PIVC issues is very important for us. Okay, but I'm afraid that we have to finish your session because we
Yeah.
now waiting for the next speaker.
Next.
Thank you very
Okay.
much, Mrs.
Okay. Thank
Ferika.
you.
Okay, so I hope that you stay tuned here because now is the time for the second presentation from Mr. Edwin Adrianta Surijah with the title The Trajectory of Marital Satisfaction. Times is yours.
Hello, how are you? I hope you can hear me, by Yanuar. Okay, so I'm going to start by sharing my screen. Share screen.
Okay, during the waiting time, for any audience who didn't register yet, please register because maybe you can get the voucher or maybe merchandise from our sponsors. Okay. during this COVID-19, the marital satisfaction also may be impacted. So maybe I will ask a question about this to Mrs. Edwin Adrianta Surijah, that maybe there is something that we can do to still improve our satisfaction, our marital satisfaction during this pandemic event. Although sometimes people think that stay at home together with husband and children every time it will can increase our satisfaction, but as a mother maybe it's also like more stress because we have to deal with our couple, our partner and our children every time. So yeah, this is time that maybe we can ask to him also.
Can you hear me?
Okay, we are waiting for Mr. Edwin Adrianta to share his screen. Also, maybe we can ask him about the influence of culture also in marital satisfaction. Oh, it seems that he can share his screen now.
Yep, I'm ready. I'm good to go.
Okay, your camera, please.
Oh, okay. Sure. Wait.
Okay, no worries.
Can you hear
Yeah,
me clearly though?
yeah, I can hear you.
Oh. Okay.
It's clear. You can
Yep.
start now.
Okay, cool. So, thank you for the opportunity, Mbak Prima, for me to deliver my study on this mini conference held by ISEC. My name is Edwin Adrianta Surijah. I'm coming from the Queensland University of Technology, Brisbane, Australia, under the Faculty of Health, School of Psychology and Counseling. My presentation today is titled The Trajectory of Marital Satisfaction, a new approach to study couple resilience. So if you follow early in the beginning, Ms. Prima said that I'm studying about psychology of love. And usually people will always ask like, why studying about love and relationship? And also, I also have this kind of invariability when I have to compare myself. For example, yesterday we have an amazing presentation coming from Mas Liberty about terrorism, and also uh, today we also heard just now from Miss Ferika about the risk of catheter for pediatric care. So why relationship? What is it about the relationship? I'm just not sure whether my screen is being shared properly, so I'm just gonna have another. Mm, 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 mm. Yeah. Okay. Let's see if I have any luck about technology today. Okay. So I said that relationship or love in psychology, sometimes people will always ask, why should we study about relationship in psychology? So before I begin with data or with facts related to this field of study, I would like to start with a vignette or a case illustration. So a lot of people been joining or coming to my consultation desk, and they've been asking about their relationship problem, and also for the unmarried one, they also been having this problem. So they came to my consultation desk. So in my opinion, in Asia or in Indonesia alone, being married is highly valued. It is as if that if you are getting married, it is the destination of happiness. If you're not getting married, then you are not happy. So due to this value in Asian or Indonesian culture, a lot of youngsters face pressure to get married, and then they will get asked several times like during the holiday season, during Idul Fitri, they will be asked, where is your husband, where is your wife, when do you get married? So it become a pressure for them to get married. And interestingly or ironically, a lot of people also came to my consultation desk for a counseling because they are not happy with their marriage. So there is like a death trap, if I could say that. So like you are being pressured to get married, but once you get married, you will also face a lot of problem. And for a lot of people, it is as if that if you are not happy with your marriage, then you want to drag people uh, in living in that living hell, sort of like in that situation. So I hope that this vignette or this case illustration help you to understand where does my research come from, because I want to help people to have a healthier relationship, especially in Indonesian culture. Marriage or being married is highly valued. That's the vignette or the case illustration. How about the fact? So when we are talking about the fact about couple relationship, a study by Apostolo in 2018, he said that 1 in 5 individuals found intimate relationships difficult, and about 1 in 2 experienced difficulties in either starting or keeping a relationship. So for me, this is an eye-opening fact that a lot of people actually found that marital relationship or romantic relationships are difficult. I often joke with friends or colleagues that if we want to be a driver, we should take a driving course, getting a driving license. But if we want to be a husband or if we want to be a good wife, a good husband, there is no courses, there is no curriculum, there is no education about that, and there's no license to be a good husband or to be a good wife. So so this is one finding, that the couple relationship is actually difficult. And unfortunately, when the relationship's getting harder, one of the endpoint of marriage is actually dissolution or divorce or separation. The data from United States through the CDC mentioned that in 2018, 2.9 out of 1,000 marriages end up in divorce. And in China, in 2006, 1.5 out of 1,000 to end up in marriages end up in divorce, and it increased to 3 out of 1,000 into the 2016 end up in marriages and end up in divorce, and 2020 is predicted to be higher. So this is quite a gloomy forecast for the marriage that would end up with divorce. I tried to look for the data in Indonesia, and it's quite difficult. For example, I tried to conduct a study in Bali. So I'm looking for data from the government there, from Badan Pusat Statistics, and they said that they do not have data about the divorce rate. But I believe that I think the data from China could give you an idea that this is what's going on in Asia regarding the divorce or marriage comparison. And if you look at the news, the local newspaper, I know that this is anecdotal, but according to the news, there are an increase of divorce during the COVID-19 period. So I think this is quite a problem that we have to tackle regarding the marital relationship. So if we are asking about why people are having this relationship adversity of relationship problem, there are 12 reasons why do people engage in a relationship adversity. Bu Prima, I just want to make sure, can you confirm to me, because I do not know whether you can see my slide? Bu Prima? Okay.
Slide. Only
Just
the
give me
first.
another second.
Okay, please share screen, please.
Okay,
Click the
so
share
you
screen.
can
Only the
right.
title, only the first slide,
Only the
and
title. Okay.
and not in the share screen mode. I mean the slideshow mode. Okay,
Okay.
please click the.
Because I did the share screen and it's on a slideshow. Still not there?
Really?
Yeah.
No, it's not there.
Okay, let me try it once again. Okay, I'm gonna stop
Maybe,
sharing my
yeah,
screen.
stop sharing and then open
I'm
again.
gonna share screen again.
Yeah.
I'm not surprised with this. Okay.
Yeah.
Okay, can you see my
Not yet.
screen now? Not yet?
Not yet.
Not yet?
Yeah. We can see your screen, but not in slideshow mode.
Oh no. Wait. Okay. I really do not know what's going on. Mm, 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 mm. Okay. What if I do not do the... Okay. Can you see it now?
Not yet.
Not yet. Hmm. Okay. I think what I'm gonna do is I'm just gonna stop using the slideshow, the full screen. I don't think it's working with the full slideshow. Okay.
Okay.
Okay. Let's try it. Like, can
Maybe
you see
just
that I'm...
yeah. It's in the fourth slide now.
Yeah. And then it's the fifth slide.
This is the fifth. Yes, this is the fifth.
Yes. I think I'm gonna stop using the full slideshow.
Okay.
Okay. I think this works better. Hopefully.
No worries.
Okay.
It's okay.
Okay.
Yeah.
Thank you. Thank you.
Yeah.
Okay, so let's get continued. So there are 12 reasons why do people end up with having difficulties with their relationships. So the first one that I really pay attention to it is the wedding enthusiasm. So Apostle actually make a list from their participants who had a relationship problem, and they end up with 78 reasons. Then they do the analysis and make a higher order, and they come up with 12 proto factors. So the first factors is the wedding enthusiasm. So I think Prima earlier said that when couple got married, they're in a honeymoon phase, they're at the peak of their happiness, and then life happen. You start to busy with your work, you get children, and then you slowly, gradually having a faded enthusiasm in your marriage. And then the second thing is the long working hours. I believe that people in Indonesia totally can relate to this experience, especially people who come in or who live in Jakarta or in Surabaya. So long working hours is also related to the shuttle time. So, for example, in Surabaya, if you live in Surabaya, you no, if you work in Surabaya, mostly people cannot afford to buy a house in Surabaya. Then you have to buy a house in Sidoarjo. It's a suburb. Then you have to travel from Sidoarjo to Surabaya through a road called Ahmad Yani, and then you will end up 2 hours being trapped in the traffic jam. So it becomes a stressor by shuttling from your house to your workplace, then coming back to your house become a stressors, and it also could affect your relationship. That's the long working hours. And then the lack of personal time and space is also quite an important thing that could reduce your marital happiness or your relationship quality. In fact, throughout the COVID-19, a lot of people have been coming to me asking for a telecounseling, and they've been saying that they're having a relationship problem. And then after we did the analysis, it's actually due to the confinement, uh, due to the quarantine. You cannot have a personal time for you. You do not have a personal space with you. So when you have a conflict with your partner, you can't really have a retreat for yourself and try to cool down things. So everything escalates due to the COVID-19 here. And then the fourth reason is the character issues. Definitely, if you are having a character problem, for example, if you're being selfish, if you always complain in your relationship, it also could affect your marital satisfaction. And lastly, uh, it, this is a specific term in Indonesia. They call it, the millennials call it bucin or budak cinta, or in English we call it clinginess. So if you're extremely clingy to your partner, it's actually will do the opposite to your relationship. It can affect or it can make the relationship worsen. So that's the five top relationship adversities or challenges that may influence your marital satisfaction or your relationship quality. Okay, so I was talking about the marital satisfaction, relationship quality, and in a lot of research about marital satisfaction or relationship quality, we always have this myth. They say that marital satisfaction throughout the family life cycle will be shaped like a U curve or U-shaped marital satisfaction curve. So I mentioned about the honeymoon phase. So uh, early in the marriage, you are at the peak of your marital happiness. Everything is new. The novelty effect kicks in, and then you are at the happiest point in your marriage. And then life happen. You are busy with your children, with your work. The novelty effect ends. Then there is a gradual decline in your marriage. And then at one point, you started to compromise. You started to accept that your wife is not as beautiful as previously. You also have a big belly. Then you start to accept everything, and then with with the acceptance, your marital relationship, your marital satisfaction gradually increase. That's the myth about the U-shaped marital satisfaction. However, this shape or this data actually comes from a cross-sectional study. So usually we would ask 1,000 of people to rate their marital satisfaction and also to report their marital duration. And then we would group the marital satisfaction level according to the marital duration. So this is the U-shaped marital satisfaction using the cross-sectional data. However, a lot of study been challenging this myth about marital satisfaction, and there is a study conducted by Van Leningham, Johnson, and Amateur in 2001. Um, Instead of using a cross-sectional study, he's using a longitudinal data or longitudinal study, and they found that marital satisfaction actually declines at each stage of marital duration. And this is their finding. So previously it was believed that marital relationship or marital satisfaction have a U shape, but apparently it declines over time. This is actually a sad finding for me, and it's alarming knowing that no matter what happened, your marital happiness by marital duration actually has the risk of declining over time. So with this finding, with all those things going on in my background or my experience as clinical psychologist, I started to wonder whether we could help the married couples maintain or regain their marital satisfaction. Is it possible to help couple to have a stable or higher level of marital satisfaction? So I stumbled upon a concept called resilience. And resilience is quite a prominent or quite a popular concept in psychology, and also I think it's quite a scientifically diverse concept. So in general idea of resilience, they say that resilience is a positive adaptation despite adversity. So by taking this general idea about resilience as the positive adaptation despite adversity, so I thought that if we bring this idea in the context of marital relationship or marriage, so couple resilience could be the positive adaptation despite adversity. couple resilience could be the positive outcomes in marital relationship despite all those clinginess, long working hours, despite the fading enthusiasm. So by using this definition as well, so we start to look at what are the positive outcomes, what is the positive adaptation in the context of marital relationship. So in my study, in my complete study, the first indicator, and I think this is the most important indicator, is the global evaluation of your marital satisfaction. So marital satisfaction is the important indicator of the positive adaptation. The second thing is, if you are happy with your marriage, you also need to have some sort of well-being in your life as well. And resilience was previously researched or investigated that resilience is associated with well-being or mental health. So in this case of a marital relationship as well, I believe that couple resilience is also related to the well-being or the mental health of the husband and wife. And lastly, a resilience study also reported that it's highly related to health status in general. So in my study, I divined that couple resilience is the positive adaptation despite adversity, and the positive adaptation is marital satisfaction, well-being or mental health, and also the health status in general. However, in this study, in this presentation, I would like to focus on the marital satisfaction as the focus of this presentation today. So with the focus on marital satisfaction, I tried to come up with one general research question. How does the couple resilience process help couples maintain or regain the initial level of marital satisfaction despite adversity? So I think this research question reflects a lot the idea of couple resilience as the positive adaptation despite adversity. So we are looking at how does couple could have a higher level of marital satisfaction despite all those challenges, all those risks or negative life events happen in their life. And today in my presentation as well, instead of looking at the conceptual framework more closely, I would like to share more about the technical aspect or the methodological aspect of my research, because I'm hoping that later on I could get some feedback or advice or suggestions in the technical aspects of my research. So I would like to show you some of my findings from my previous research. So the first data that I show you here is actually a cross-sectional observation from 300 couples. Cross-sectional observation from 300 couples. This is data from my study in 2018. If you are looking at me that I'm looking nervous here, because I think that I assume there is also a problem with the share screen again. Bu Prima, can you tell me, am I in the correct slide? Bu Prima? Okay, so I think I'm just gonna proceed with caution. Okay, so hopefully the audience know what I'm trying to share with you about data from my 2018 study. So this is data from a cross-sectional observation of marital satisfaction in 300 couples. So the data that I'm trying to show you suggested that between husband and wife as the grouping variables, there is no significant differences in the data. So in the data, the median was positioned in 30. So that's the most common answer or response from the participant. So the participant mostly reported that they are considered highly satisfied with their marital satisfaction. So with the data as well, that you can see the interquarter range between the husband and wife do not really differ. So we can conclude that there is no significant differences between the husband and wife based on the data. So I'm looking to mimic or mirroring the process by the previous researcher by outlining the data using the marital duration as the grouping variables. So if you look at the marital duration from the newlywed, phase 1, phase 2, and phase 3. So newlywed is the first 5 years, phase 1 is the 5 to 10, phase 2 was the 10 to 15, while phase 3 was above 15. You can see that actually there is no significant differences as well. The median was located at the 30 points, and the interquarter range also did not really differ between groups. So from this finding, we could actually see that my data challenged the myth about marital satisfaction, the U-shaped marital satisfaction trajectory. However, we also have to acknowledge that cross-observational study has a limitation, because when people being asked about their marital satisfaction, they tend to overestimate their marital satisfaction level. So the marital satisfaction level will actually tend to be overestimated. So if you look at the data, it's actually positively skewed to the left. That's what happened. So I'm trying to shorten the interval of their observation and also ask them to observe their marital satisfaction repetitiously. So I'm using a repeated measure design, and I have this data with me. This is actually my current study. My current study and it's still on a pilot trial basis, so this is not yet completed. I'm using a 6 weeks observation from the participants to report their marital satisfactions. And so if you look at the page section, page 1, page 2, page 3, until page 6 is the week 1 up till the week 6, and then they will report their marital satisfaction. And you could tell that there is a dynamics on the median. So the median from week 1 to week 4, for example, has a dynamics over time. So when we ask them to report their marital satisfaction in a shorter interval, they will actually report the dynamics. So initially, when they said that, when it was said that Indonesian participants would tend to overestimate or trying to look good or trying to look satisfied in the relationship, but when we asked them to report their marital satisfaction in the repetitious or repeated measure design, you could see the dynamics of their marital satisfaction level. However, if the box plot here that I showed you do not really explain the dynamics closely, so I would like to go to the line graph here. So in the line graph, you could clearly see that there are couples or there are married individuals, for example, individuals number 5 with the blue line. Over time, they reported a stable marital satisfaction level. However, for the participant number 7 with the purple line, you could tell that from the week 1, they reported the lowest marital satisfaction level compared to the other participants. However, on the week 2 and week 3, there was a slight increase. On the week 4, there was a steep and a sudden increase in the marital satisfaction. But unfortunately, for the following week, there were a gradual decline. So you could see that there is a gradual dynamics over time that we can observe from the marital satisfaction. So I also began to question, what if I even shorten the interval further? What will happen if I shorten the interval further? So I do not know. I'm not sure whether you can see the slide properly, but I'm gonna proceed again. So this is the marital satisfaction level reported by 194 participants in 30 days observation. So instead of asking them to report their marital satisfaction weekly, I asked them to report their marital satisfaction in 30 days in a daily basis. So if you look at the box plot, it also, because box plots is an aggregate description of the data, you could see that most of the data do not really differ much, but you can tell from, for example, from day 1 and day 2, there were significant differences. For example, from day 1 and day 2, there is a significant decrease in marital satisfaction. In day 2, the median is located below the interquartile range of the observed data. And also, you can tell from the blue section of the data as well. If I want to look at the individual dynamics, then I would go to use line graphs. But if we are using a line graph for participants above 100, we would end up with a mess. We will end up with a huge mess like this, as being shown in the presentation slide. So you can tell that in the line graph there are a lot of overlapping data here, and we cannot see the pattern. Even if I try to look at the if I try to remove the dots, it was not also really helpful. Even though if I look at the data closely, I could definitely tell there is a dynamics over time in the marital satisfaction level as well. So that's why I'm coming up with a machine learning called growth mixture model or latent class analysis. A growth mixture model or latent class analysis would analyze the time series data, and they would look for the patterns coming from the observed data. So with those messy line graphs being provided to you earlier, this is an illustration by using the growth mixture model. This is not the actual result from my study. But by using the growth mixture model, I would be able to analyze the pattern of the marital satisfaction trajectory. So if we go back to the research question early on, I could question myself about whether I could see, is there any married participant having a stable marital satisfaction level? Is there couples who share similar trajectory of having declining marital satisfaction level or increasing marital satisfaction level? So by using those analysis, I could apply it to the idea of couple resilience as the trajectory of higher level of marital satisfaction despite adversity. So that's the idea for growth mixture model. So today, these days, I'm learning about growth mixture model, the machine learning, and how will this analysis approach will actually help me to analyze the data better. And by using this growth mixture model, we can actually even dig further and ask deeper questions, such as what factors affecting the pattern. So for example, early on, I was mentioning about the trajectory or the pattern of the marital satisfaction. That's called unconditional model. However, if we start to put the factors, if we want to know what factors affecting the trajectory of the pattern, then we could have the conditional model. What are those factors? It can be the traumatic events. It can be the daily hassle. It can be those 12 reasons being suggested by the apostolo early on. So in my research, in addition to asking about marital satisfaction level, I also asked the participants to report the daily hassle that they encounter in their life, in their marital life. And also, we could also analyze whether the factors affecting the pattern are actually the barrier or the factors that help the marital satisfaction to maintain a stable trajectory. The barrier, I hypothesize that coping strategy is the prominent factor that helps the married individuals to manage their stress, to manage the long working hours, to manage the conflict happen in their marriage life. And the coping strategy will actually help them to maintain the healthier trajectory of marital satisfaction. And apparently, social support is also the prominent factor in helping couple relationship to have a healthier trajectory as well. So we believe that if you're having a better support from your family, if you're having a better support from your friends or colleague, it will actually influence your marital satisfaction as well. And lastly, a lot of study been saying that a sense of belonging, a sense that you feel belong in the family, a sense that you feel belong in the community, the sense that you feel belong in associations such as ISAC, could actually become a barrier, it could become a protective factors in your marital relationship as well. So the challenges that I encountered, so I would like to share as well, those are the design, those are what's going on in my study right now. I'm asking the participants to report their study, but due to the
Sorry,
COVID,
Mas Edwin,
yeah,
maybe you can finish your presentation within next 1 minute because we
sure,
need.
I will do it.
Okay,
So
thank you.
the challenges due to the COVID-19, I have to change all the design into an all online survey. Thus, I would have a lower response rate. And unfortunately, the growth mixture model requires a larger sample size. So I'm looking for a different alternative right now. So where to go? So today I'm doing the data collection. I'm started to calculate the statistical power, and due to the lower response rate, thanks to the COVID-19, I'm having a challenges with the data analysis. So if friends and colleagues here have an idea about how should I approach this data analysis, then it would be greatly appreciated. Thank you for the opportunity, and I'm terribly sorry for all the hiccups within my presentation, and hopefully it gives you insight somehow. Thank you.
Oh,
Back to
thank you very much, Mr. Edwin. It was very nice
Yeah.
presentation, and actually, I'm sure that a lot of questions that want to be asked for you. So we
I'm actually deeply sad today because the presentation was a mess.
okay. We already have one question from Mr.
Yeah.
Hakim Mashur.
Yeah.
Mr. Edwin Adrianta, I do have a question. Since you mentioned about marital satisfaction level, how do you measure or determine the level? Thank you.
Cool. Okay. So in psychology, we have this so-called inventory or measurement to measure marital satisfaction level, and each marital satisfaction inventory will have different approaches. So I've been studying in the past which one is the best marital satisfaction inventory. So, for example, there was a marital satisfaction inventory that is asking about several aspects of marital satisfaction, but those inventory was heavily biased with the social desirability. I think I mentioned in my presentation, people tend to report their satisfaction level higher than the actual condition because they want to be, look good in front of the researcher. So based on my previous study, I'm using simple global evaluation of marital satisfaction. It's adapted from Kansas Marital Satisfaction Scale. It has 3 questions, basically asking about how satisfied are you with your relationship, how satisfied are you with things going on with your relationship with your partner. So the more general, the more global evaluation, it's a lot more accurate. That's based on my experience.
Okay, thank you very much, Mr. Edwin. I'm so sorry. Actually, I want to ask question, and also it has some questions again, but because the time constraints, so we now come to the closing statements. So, Mrs. Ferika, maybe this is your times to give closing statements. Time is yours.
Okay, thank you, Ibu Prima. It's very was that nice and interesting presentation, also from Mr. Edwin. So I just want to say a couple of sentences here that I really enjoy this collaboration with Isaac Beauty and also Kelas Bersama, and also uh, regarding my studies, I'm really hope that in the future that Indonesian children particularly will have a good outcome of PIVC insertion and also care for their hospital stays, so they will not have any traumatic experience anymore regarding the PIVC insertion and care. So, and also the lower the incidence rates in PIVC complication will have like improve the patient satisfaction to the hospital. I think that's. I think
Thank
that's
you
all for
very
my.
much.
Yeah. Thank you, Bu Prima.
Okay, thank you. And now, Mr. Edwin, this time is yours to give a closing statement.
Okay, so the intention for me to join this conference is actually gaining feedback or suggestion from the other participants. So if other attendees have any idea about data analysis, machine learning, definitely buzz me a call and I'll be glad. And I'm really curious with our next session from Rizkan Mafrur from University of Queensland. He will be talking about uh, automating the data visualization. So I'm gonna stay tuned for that, and hopefully I could get some insight from him as well. I think that will be my closing statement.
Okay, thank you very much for all of great speakers today. So for the audience, please stay tuned because next session will be moderated by Mr. Rawan Sugianto, and we will have 2 great speakers also, Mr. Muhammad Lutfi Hamidi, with the title Friedman versus Elkington, Beyond the Triple Bottom Line in Islamic Banking, and also Mr. Rishan Mahfur with the title From Data to Insight, Automating Data Visualization through Recommendation. Okay, thank you very much for all of the audience. Thank you for your participations. Bye. See ya.
Bye. See ya.